pressure needs to be above, or we want it like at 60%. If it is less than 30, the person is in cellular ischemia. So if we're even getting anywhere near 30, we're going to need to adjust something, usually blood volume or blood pressure. So we're going to need to notify the MD, because if we get to the point of cellular ischemia, the cells are going to start to die. So anytime you see a question, especially if if it gives you in the question intracranial pressure and blood pressure, right off the bat, you know you need to calculate the MAP minus the ICP, figure out what the CPP is, and if it's anywhere near 30, you better be doing something as a nurse. So just a hint, if you see a question anywhere, even on NCLEX with the ICP in it, and it gives you a blood pressure, because it's never, I'm not going to give you the MAP and the ICP, that's too obvious. You need to be able to calculate it yourself.
I know how to calculate the MAP.
I'm going to go over it right now. This is the formula. The ICP, luckily you don't have to calculate, it's going to be given to you. So let's go back up to figure out how you get an ICP. All right. With intracranial pressure, there's going to be catheters. They're going to be inserted in their head, and this is going to automatically hook up to the monitor, just like I'm doing EKG, the heart rate, it gives you the ICP. So ICPs are directly measured with these types of devices, and there are a couple different places they can put the ICP catheter in. So we can put it in the lateral ventricle, in the subarachnoid space, in the brain itself, or in the subdural space, and then under a bone flap. So it's just a couple different locations. When I am looking at a patient that has an ICP monitor, some things that you need to know, or if there's a question on it, it all comes down to safety and infection control for this catheter, because this is going directly into the brain. So the nurse has to be most aware of keeping the patient safe, which means what position do they need to be in, and then infection control is the other most important thing, so sterile technique. So here are the locations of the ICP monitors. There are the fiber optic catheters that they can put directly into the ventricles. Things that you need to be able to do. You need to check their level of consciousness. You're going to need to do neuro exams frequently. Make sure that they're oriented to person, place, and time. We're going to be checking their pupil size, assessing the strength of their hands and feet. Can they follow commands? We need to watch their vitals, and we're always going to be looking at pain level. So they go in, they drill the burr holes, they can place these intraventricular catheters under a bone flap or in somewhere in one of the spaces that we talked about. It is going to help to measure the ICP. And it also, besides giving us a number, is going to give us some waveforms. So just like the cardiac monitoring, we can also see brain monitoring waveforms. There are 3 different types of waveforms that we can see, and they're going to be like peaks and troughs. You don't necessarily have to memorize these, but do realize that there are the 3 different types. So A waves are usually associated with compromised cerebral perfusion or a deteriorating neurological status. B waves, these are going to be seen when the ICPs are somewhere between 20 and 50. Usually it's intracranial hypertension that is causing these. And then C waves are just more associated with higher ICPs. And I didn't even put pictures of the waves because I'm not going to ask you to identify it. Just realize that they exist. Some things that we can do with the ventraloscopy catheters. I gave you a reading on the care of the ventraloscopy catheters, or it's a skill. I think it's in the advanced skills. Make sure that you look it over. Sterile dressings, definitely to take care of these. You can drain off cerebrospinal fluid with these catheters if need be in order to decrease volume. It also gives you the ability to instill medications. So make sure that, again, you read over the care of a patient with this type of catheter. Normal ICP should be 0 to 15. Anything over 15 is too high. Patients should be in the lateral recumbent position when they have this catheter in. And the most important thing besides sterile technique you're going to do is hand washing. The pressure transducer should always be at the eye level when we are having a patient with an ICP. So if we adjust the head, we need to adjust the transducer as well. Most of the time, there is a stop cock or a three-way. I told you we can drain out, CSF if we need to. It could be hooked up to a drainage system, all different options with the intraventricular catheters. Now, this doesn't work for a catheter that's just under a bone flap or if it's in the brain tissue itself, that just gives you the ICP. But if you have intraventricular, this is where more often seen with patients with hydrocephalus, though, to drain off cerebral spinal fluid. Now, as for draining cerebral spinal fluid, we do need to watch if the drainage stops. We don't want to increase intracranial pressure. So if we see intracranial pressure going up, now we've got to look at the drainage from the cerebral spinal fluid or from the tubing and see if there's a kink or some kind of narrowing. Is there any problem with the connections? The height of the system, remember I told you transducer needs to be at the level of the eye. We're always going to assess for leaking, so if there's liquid on the sheets or something around the person. And then anytime you think the tube is clogged, if you've checked everything and you can't figure out why it's not draining anymore and the ICP is rising, we need to let the physician know because we're going to cause an increased intracranial pressure at that point in time. So I did tell you how to calculate the CPP, which the CPP is the difference between the mean arterial pressure and the ICP. So the ICP should be given to you because you have the transducer in. We're just going to subtract it from the mean arterial pressure. And then we're going to be able to know, are we perfusing the brain adequately? Now, to say the brain is being perfused adequately, what we're looking at is there should be about a milliliter of blood that is passing through every 100 grams of brain tissue every minute. So that's about 50 milliliters per minute through the 100 grams of brain tissue. This says my brain is being perfused adequately. Body automatically does it through pressure changes and volume changes, but again, we have to monitor it. And if it is even remotely getting close to 30, we need to notify the physician from there. The biggest factors that are going to affect cerebral perfusion is, again, CO2 levels. So we're going to watch the CO2 levels carefully. The other thing is going to be acid-base changes, so hydrogen. Any acidic changes in the body cause vasoconstriction. And then our O2 levels, we have to watch O2. So this is looking at normal breathing versus hyperventilation, and you can see the vasoconstriction that's going on with the hypoventilation, the lack of CO2. The main thing I need to know here is that oxygen has to continue and blood flow has to continue. So most of the time, you will see high oxygen levels. And when we talked about ventilators, I was like, if you're looking at your APGs and you're at 100%, you need to tell the physician because it's too high. That does not pertain to a patient with ICP vasoconstriction going on. We might need them to be 100% O2 in order to give them enough oxygen for their brain. Questions on that idea? All right. I'm going to leave it here. So this is all the background knowledge at this point. Cerebral edema is going to be the main thing that is going to cause increased intracranial pressure. There's going to be 3 different kinds. We're going to talk about injuries, and we're going to talk about the care of a patient who has increased edema of the brain. But I guess I'll try and get it all next week, because you guys are like losing it. I'm pretty sure everybody's eyes are crossed over by this time. We're going to try and get